I've been asked to talk about the reality of changing quality of care at birth. And what I do today is just give you a quick overview of what is happening in this area. Obviously, it cannot be comprehensive because the time is limited, but I'll just give you an overview of some of the things which are happening today. Now, we know that the quality of care matters because in the past, as Richard showed, there's a lot of emphasis, the focus has been on coverage. We have to have our skilled birth attendants, we should have X number of antenatal care visits, X number of postnatal care visits, etc. Everybody is focusing on that. One good example is in order to increase the skilled birth attendant rate, of course, countries have various strategies to increase the coverage rate. One is, of course, training more skilled birth attendants. The other is to make, call some people skilled birth attendants. And the third strategy was to bring many women into facilities through various incentives. Now, Joy showed those slides from Ghana, where you can see the overcrowding, and this is true about many other countries where there's a massive increase in the number of facility births without a concurrent improvement in the quality of care. So the problem is increasing coverage has not been matched, unfortunately, with better outcomes. And so one could say that, in fact, more facility births, more facility deaths. And that's, looks like the place where women actually go to die rather than giving birth. And one major roadblock that we know is the quality of care. Now, in response to this, we have been working over the last few years focusing on quality of care. In 2012, in the Countdown report, there was a panel on quality matters. The importance of quality was discussed. And in 2013, many of us in this room were at that meeting on quality of care, trying to come up with how do you measure quality of care, how do you monitor quality of care at a global level. And this meeting, which was convened by WHO and the Partnership for Maternal, Newborn and Child Health, came up with several indicators. There were 19 indicators for maternal, newborn, child and adolescent health, child health. 6 of them were for maternal, which I'm just showing you here. This is not the exact wording of the indicator, but just the domains it covers. We had some for newborn, 5 for newborn, 4 for child, and 4 cross-cutting indicators going across. And as you can see, these are indicators or these are domains which are covering the major causes of maternal and newborn mortality. Of course, stillbirths haven't been left out. It's under the maternal, and it's looking at the intrapartum stillbirth rate, looking at as an index, as a marker of the quality of care during childbirth. Now, we also know, having said that, in 2013, there was this large study of over 300,000 women giving birth in several countries in Africa and Asia and in Latin America. And where they noted that even these countries with very high maternal mortality rates, the coverage of the intervention that we believe will work, for example, the use of oxytocin, use of magnesium sulfate, etc., were quite high. In fact, they were in some cases higher than those in the low burden countries. So one wonders whether it's just the coverage which matters, or is there a lot more than just having just a coverage rate as a marker of the quality of care. So obviously, maximizing coverage rate is essential, but that's insufficient to achieve significant maternal mortality reductions. That's the other problem is, of course, verticalization of care. These magic bullets. People come up with magic bullets saying you give this to the mother and she'll be okay, save a whole million maternal deaths, or same thing for the baby. So that is something which can cause potentially more harm than good in terms of the comprehensive care that all women and babies should receive. Now, we also looked at the facilitators and barriers to quality of care in maternal, newborn, child health. This is a systematic meta-review of several reviews. And among the things you can see, these are fairly common. This is specifically looking at maternal health. And the facilitators for good quality of care was communications, regular and active communications between the care provider and the end user, respect and confidentiality, engaging the user in decision making, continuity of care, and of course, effective audit and feedback mechanism. And on the other hand, you had these barriers, which were again related to communications, lack of accountability, variability in guideline implementation, and of course shortage of resources. These are realities, but these are realities which should be addressed if one has to improve the quality of care. More recently, Megan Boren, from who's now currently is working in WHO, looked at facility-based deliveries. What are the facilitators and barriers to facility-based deliveries in low and middle-income countries? And if you look at these are very similar to the 3 delays models. Okay, you have traditional and family influences, distances from facilities, which are the first 2 delays, related to the first 2 delays, and then you have, once you reach the hospital, you have cost of delivery, you have the low perceived quality of care, and fear of discrimination. These are kind of basically no-brainers. I mean, you do these studies, but you know what the problem is. The next thing is we need to know how to address it. In terms of what are the facility-level inputs which can improve the quality of care, and this is from Zulfi Bhutta's group in Aga Khan University. Social support, we know that. Social support, if you have a birth companion, that's something which gives you more satisfaction during labor. Less noise, less abuse in labor, the shorter labor, more normal deliveries, and less analgesic requirements. If you motivate the workforce with stress management, feedback sessions, you reward incentives, and have flexible work schedules, there's certainly a lot more motivation, and the workforce is able to deliver better. Midwifery-led care, understandably, is better in terms of fewer interventions. Obstetricians find it very difficult to sit on their hands. So, it's something which I think the more we promote midwifery-led care for as many women as possible, you're more likely to achieve good quality of care. In terms of district-level inputs, again from Zulfi Bhutta's group, there are positive level influence of supervision on providers' knowledge and on the satisfaction, including local opinion leaders in promoting evidence-based practices, again, improves compliance. And lastly, you have the use of vouchers. Now, whether that increases quality, I'm not sure. It certainly improves stillbirth attendant rate and institutional births. Now, I'll now talk about a couple of tools which have a potential, some tools which may have a potential to improve the quality of care or at least adherence to certain practices. The first is the WHO Safe Childbirth Checklist. Now, these 2 papers here, one in the International Journal of Obs and Gynae and the other one in PLOS Medicine, describe the process of developing the checklist. Now, the checklist is 2 sides of an A4 sheet, and here you have about 29 interventions or essential care interventions are included with 4 pause points. So here there are 4 pause points with the provider pauses for a moment to look at and see whether these things have been addressed. So the first one is on admission. For example, I'll just read a few of them. Does the woman require, does she need referral? Okay, if she needs referral, has it been organized? Has a partograph been started? Then they address some of the more common problems like infections, magnesium sulfate for preeclampsia, eclampsia, and HIV, so you have nevirapine and so on. So a few things which are addressed on admission. The next pause point is just before pushing or just before cesarean section. And the third pause point is soon after birth, within an hour of birth, looking at the mother and the baby. And lastly, before discharge, there are a few things which need to be addressed. Now, this was tested in small pilot sites, but there was a pilot before-after study on over 1,000 patients, 1,000 women in India, where they looked at what happened before and what happened after introduction of the checklist. There is a marked difference, as you can see, from an average of less than 10 of the 29 practices being implemented to over 25, about 25 of the 29 practices being implemented in a very short space of time. Now, this has shown adherence. Of course, we don't know yet whether this is something which is going to be sustained in the long run. There is a large study which is going on in India, in the state of Uttar Pradesh, looking at the implementation issues. Hopefully that will measure impact. But people have always asked, why Uttar Pradesh? I mean, if you know India and if you know Uttar Pradesh, that's the most difficult state to work in India. If anything can be achieved in Uttar Pradesh, it can be achieved anywhere in the world. So probably we'll know. In fact, week after next, there is a meeting in Lucknow to see what is happening. I know from previous meetings that there have been lots of challenges in getting this going, and that's a lesson that we would learn rather than looking for the impact to see how this can be done. The other one, which is often, it's been there for so many years. It came out of Africa, from Zimbabwe, and adapted in many other countries, but hardly used in many places where it should be used. Now, Tina Lavender sitting in front of me here, she has done the Cochrane review, and her conclusion was that there's not sufficient evidence. And she's quite right, because the large WHO trial of 35,000 women in South Asia has not got into the trial. Now, that trial did show that it benefited, it reduced stillbirths, it reduced the number of cesarean sections, etc. But that, unfortunately, for various reasons, has not gone into the trial. But this is an area where we know, from those of us who have used the Partograph, know it works. But the problem is, why aren't people who should be using it using it? And that's what we need. Rather than developing a new tool to monitor labor, we should see why this is an old tool, or how can it be made to work better. So that's another area where I think people here, if you are interested, should contact Tina and discuss the ways forward. The other tools which are very useful in looking at the quality of care are the tools which are related to maternal death review and maternal death and near-miss reviews. These are just maternal, but we haven't forgotten the baby. We are working currently on the newborn and the perinatal death review tool, so that will come up, and soon we'll have a child health mortality assessment tool also. So these are things which need to be followed up. Now, the other thing I wanted to share with you was these two documents which have come from India. And this is when the civil society takes over. Civil society realizes the government is not doing very much. The professionals are not doing very much. So what do? They go into this area of looking at why women died. And this is where there are two good reports, what actually happens. Although there is a system in place on paper, you have emergency obstetric care facilities which are functioning, doing hysterectomies during the daytime. At night when they come, they're referred from those hospitals all the way, 4 or 5 hours away for further treatment, people dying on the way and so on. So it's a very good set of reports which have come from civil society organizations. There are gynecologists, obstetrician gynecologists involved in this group, so it's not that they are just advocates, there are technical people involved in this group. Okay? Now, having said that, there is also this one which came out last month from the UK. And in fact, yesterday when I was listening to the news, there was a report. I mean, I didn't want to show any slides of bad pictures from Africa or from Asia, because on the news yesterday was in Cumbria, the Barrow in Furness, the hospital, and there was a lot of news there. So problems arise everywhere. It's what we need to do after that. But this report actually sounds very good when you read the executive summary that, of the 10,000 women who were interviewed or who were contacted for interview, about 45% of them agreed to be interviewed, and 16% were BME, which is a new term which I came across when I read the report, but I understand what it means, and you all know what it is. And 24% born out of UK, 13% single parents, 58% midwifery care, excellent. 35% had the same midwife every time, but 1 in 5 had 5 or more midwives during their care period, which is not the best. But even having said that, the overall experience was very positive, right? But less so among the minorities who reported poorer staff communications and not being treated with respect. So everywhere, in every part of the world, you have the same problem when you are, there is a group which is not treated adequately, and that's something which we should try as part of the quality of care, how we can improve it. A couple of things which struck me. These are all low-risk, presumably low-risk women. All of them had normal deliveries, but 47% of them had continuous fetal monitoring. I'm not very sure why. That's something we can discuss. 26% have cesarean section. And again, these are normal women. Why do you have a cesarean section rate of 26%? That's not addressed in the report. A few years ago, there was a problem a little north of where we're sitting today in one of the hospitals. And as a result, the Royal College, this is the professional organization, society's response, came up with a maternity dashboard on how to monitor performance. And the maternity dashboard is here in the good practice, whatever it's called, number 7 in 2008 talks about the maternity dashboard, which includes clinical activities, the workforce, how many staff are on leave, etc. Then the clinical outcomes and the risk and so on. And this is something which has been used, or I'm not sure whether it's still currently used, but you can see the traffic lights where things are green, things are red, which needs some urgent action, and amber, which needs close watching. And more recently is the FIGO guidelines, which have come up on mother-baby friendly birthing facilities. We will be talking later on this afternoon. We have a session on the Every Mother, Every Newborn, the quality initiative around the time of birth. So some of this will be covered in that, but again, FIGO has come up with a 10-point certification scale proposal for mother-baby friendly facility, quite similar to the baby-friendly hospital initiative, just that here, unlike the baby is also mentioned, probably one point, which is skin-to-skin mother-baby care and breastfeeding. So there's a lot more things that we need to work together to make sure that we have the mother and the baby addressed together. Lastly, I'll stop with ongoing work, which is going on in the WHO vision on quality of care. And in the framework, we are looking at, Richard talked about efforts to achieve universal health coverage. So as part of that, this is aimed to provide all mothers and newborns access to the healthcare system. But as part of this, it should also ensure that every mother and every newborn receive quality care during pregnancy, childbirth, and the postnatal period. The quality of care is defined for this definition is that the extent to which health services provided to individuals and populations improve desired health outcomes. In order to achieve this, we are looking at safety, effectiveness, timeliness, efficiency, equity, and people-centered. Now, Joy did show this slide, the famous slide on the triple bang for the buck, and this is where you get the most returns when you address care during labor. You try and reduce maternal deaths, newborn deaths, and stillbirths. And that's where the focus is going to be. I will not go too much into details, but we will be focusing mainly on the area around labor and childbirth care. That's for the start. We focus on that. We work forwards on that. In terms of the framework, under the health system framework, right on top, you're focusing on quality of care. We are looking at two areas. This is, again, a modification adapted from Louis Hulton's work, the provision of care and the experience of care. So on the provision of care, you're looking at evidence-based practices for routine and emergency care, actionable information system, functional referral system. And of course, on the experience of care from the patient's perspective, you have effective communication, respect and dignity, emotional support. And across, you have competent and motivated human resources, essential physical resources available. In terms of, so that's the structure is within the health system, the processes I've just described. And in terms of outcomes, you're looking at individual and facility level outcomes. In terms of facility level, you're looking at key coverage of key practices, and look at people-centered outcomes for experience of care. And then, of course, all these will lead to better health outcomes. In terms of quality of improvement strategy, this is the framework that they're looking at, starting with establishing a leadership group, looking at situation analysis, adapting service delivery standards, identifying interventions, and the PDSA cycle basically, plan, do, study, and act, and move forwards. So how do these two things, the quality framework and the PDSA, unfortunately it hasn't come up very well, the colors don't come up very well, but within this, within this you have research right on top, and on the other side you have capacity building. So you have the WHO guidelines that we develop, which contribute to service delivery standards and effective intervention strategies, which are used to adapt service delivery standards, identifying interventions. And finally, you have the measurement of indicators and methods which we work towards measuring the quality and outcomes. So that's in a nutshell, the framework. And I'd like to conclude by saying, yes, it's possible to achieve quality because every mother and her baby deserve quality health care. So thank you very much.